Hello, welcome to the June 2020 Registry Partners Coding Break. This month we will be reviewing grade clinical and grade pathological for the bladder site. The objectives of this presentation include understanding the differences in the clinical and pathological timeframe, the importance of referring to the grade clinical and grade pathological notes. We will emphasize Note 3, which is the priority order, and end with some common questions or scenarios you may encounter when abstracting. This table illustrates the differences when determining grade clinical and grade pathological. For grade clinical, we are to assign the highest grade from the primary tumor assessed during the clinical timeframe, which would be prior to primary site surgery. Please keep in mind, a TURBT qualifies for clinical grade only. This is noted in grade clinical and grade pathological Note 5. This also correlates with AJCC staging qualifications. A TURBT removes the tumor from the bladder. It is performed to treat early stage bladder cancer when the cancer has not grown outside the inner layers of the bladder. On the other hand, in order to code grade pathological, you must have a resected specimen from a cystectomy or partial cystectomy. This is different than a TURBT, since the primary site is completely or partially resected. I also wanted to highlight Note 2 for grade pathological, which does instruct the CTR to assign the highest grade. If the clinical grade is the highest, then you would assign the clinical grade for both the clinical and pathological grade. You may also assign a clinical grade if a resection is performed and there is no grade documented, or if there is no residual cancer. Notes that are similar between grade clinical and grade pathological include neither can be left blank, the priority order for urothelial cancers, and then adenocarcinomas and squamous cell carcinomas. Note 4, which states undifferentiated and anaplastic are grade 3, and both emphasize a TURBT results in a clinical grade only in Note 5. The final note for grade clinical and grade pathological is one to code 9, or unknown. Both include to code 9 when the grade from the primary site is not documented. We should not use a grade listed for a metastatic site. The grade must be taken from the primary site. An unknown clinical grade would also be assigned if no clinical workup is performed, such as in an incidental finding. An unknown pathological grade would be assigned if there is no resection of the primary site, meaning no cystectomy or partial cystectomy, or if it's a clinical case only. A grade pathological code 9 is assigned if the patient receives neoadjuvant therapy followed by a resection. That would then be a post-therapy grade. Along with, if only one grade is available and you're unable to determine what time frame. Similar to grade clinical, if grade is checked as NA on the CAP protocol and no other grade information is available, then you would assign a code 9, which is unknown, for grade pathological as well. The Note 3 importance. For urothelial cancers, we are to use code L, H, and 9, which is low grade, high grade, or unknown. If the pathology report only states grade 1 through 3, which is well, moderately, or poorly differentiated, then we use code 9. For adenocarcinomas and squamous cell carcinomas, we are to use codes 1 through 3 for the grade. If the path report states low or high for either of those histologies, then we code to 9, unknown. Here's a question that was posted on the Cancer Forum, along with the associated link. The question was, what grade is assigned for a bladder primary in which the urine cytology is high-grade urothelial carcinoma, but the TURBT indicates low-grade urothelial carcinoma? The response was, the TURBT should be followed for grading bladder primaries. High-grade cells floated in the urine could be from anywhere in the urine tract, from the bladder, renal pelvis, ureter, or urethra. We are to code the clinical grade based on the TURBT, which is low grade, or code L. Another 2 questions. Can you use the WHO grade for bladder primaries? The response was the WHO grade may be used for urothelial bladder cancers. You may use the WHO grade of low or high. The other question was if a TURB is positive for undifferentiated malignant epithelioid neoplasm with focal spindle cell features, what is the grade? Per note 4, undifferentiated is a grade 3, so we are to code the clinical grade 3. Note 4 also includes anaplastic. Again, I have included the cancer forum links as a resource. Finally, the last 2 questions are testing the priority order. A TURB is positive for grade 3, poorly differentiated urothelial carcinoma. This would be coded to a clinical grade of 9. Reference note 3, where low and high grade are the priority for urothelial carcinoma. Similar in the second example, a TURB is positive for high-grade squamous cell carcinoma, which would be coded to a clinical grade of 9. Grades 1 through 3, well to poorly differentiated, are the priority for adenocarcinoma and squamous cell carcinoma. Again, please reference the notes. Thank you for tuning into our coding breaks. We're wishing everyone a safe and happy summer.